Hi guys, this is Jody. This is your presentation for week 8, and we are talking about drugs for the GI system. So the first thing we're going to talk about is peptic ulcers and drugs that we have to treat peptic ulcers. So one of the big ones that you'll hear is omeprazole. Omeprazole is a proton pump inhibitor. Another one that you will see a lot is pantoprazole. So again, ends in that ZOL. And that is the generic for Protonix, which you tend to see a lot out in practice. But again, it's those drugs that end in the ZOLE. They are proton pump inhibitors. They really want to use these for a short period of time, so they're finding that people who use them long term are more at risk for osteoporosis, which is that bone loss. So they want to limit this to the lowest dose and shortest duration of therapy. So I can tell you my daughter was on this for a short period of time because she was having a lot of stomach pain, stomach issues. And so they put her on this, but it was just for a very short period of time. When you have patients who have peptic ulcers, or they're at risk for peptic ulcers, you want to look at their diet. What are they eating? Are they eating high acidic foods? Are they eating enough? Sometimes if people don't eat anything at all, like your anorexic patients, people who struggle with that or for some reason have been so sick and can't eat, they have the stress. And then on top of it, they have all the gastric acid that's in the stomach and there's no food to interact with. So it can irritate that stomach lining. If you have a patient that comes in with a GI bleed related to a peptic ulcer, that stomach ulcer, they may put them on a Protonix IV drip, which is that pantoprazole. So you may see a patient on an IV drip of a Zolmed for treatment of stomach ulcers. Very common one that you see a lot are your antacids. This is if you're having some GERD, that gastroesophageal reflux disease or disorder. You can also see this used as calcium supplementation, because that is essentially what it is calcium carbonate. These are chewable tablets, and they should be chewed before swallowing. You always want to make sure that if a patient is taking an antacid, that they are drinking a full glass of water with it. And that's just going to help the stomach in and of itself to have that water and this antacid that actually combat the acid in the stomach. If a person is using a lot of this, they can end up hypercalcemic, which is a high calcium level. It can also lead to some kidney stone development for clients with a history of kidney stones. And then we have drug therapy for nausea. So mostly we know that if people are at home and they're feeling nauseous, we really push the ginger ale and crackers and those bland type of foods. If somebody is in the hospital with extreme nausea, we can treat them with something called metoclopramide. We do not want to use this if there is a suspected obstruction. So if you have a patient that comes in with extreme nausea and stomach pain, before we just start treating the symptoms, we want to determine that underlying cause and make sure that there isn't a bowel obstruction of some kind. This is a dopamine antagonist, so we want to watch for those extra pyramidal symptoms. Sorry, that's a hard one for me. And the EPS symptoms are those that are very similar to people with Parkinson's. So it's a very stiff gait, rigidity, slow movement, tremors, that tardive dyskinesia, which is the irregular jerky movement. So we look for those as a side effect of more prolonged use of this medication. It does have a sedative effect. With anything with a sedative effect, we would want to make sure that they're not out, if they were taking this at home, out driving, anything like that. It can also lead to something we call neuroleptic malignant syndrome. And this, a patient with the neuroleptic malignant syndrome would present with high fever, confusion, rigid muscles, variable blood pressure. That means the pressure could be high and then go low, sweating, and fast heart rate. So this one isn't used lightly, but we do use it in the hospital for patients with nausea. There's also a medication called ondansetron. Dazatron. This is a serotonin antagonist. This has some significant adverse effects, including dizziness. So we would want to put a patient on fall precaution. Because it is a serotonin antagonist, we can actually see serotonin syndrome. That's agitation, restlessness, and insomnia. Torsades de Pointes is a lethal dysrhythmia that you can see on a heart monitor. And then Stevens-Johnson syndrome is significant rashing all over the body. If you guys Google that, I think it'll shock you to see some of the images that you'll see with Stevens-Johnson syndrome. So those are the adverse effects of this. So again, adverse effects, not ones that we typically expect to see, but we know that if somebody is taking that, this could happen because it is a serotonin antagonist. Drug therapies for constipation. Most of your patients in the hospital are going to be on Ducosat sodium. This is Colace. This is a stool softener. Clients with a risk for constipation should take this. I will tell you, any patients that are on an opioid drug for pain should be on a stool softener, because we know opioids in the hospital will slow down GI motility. Okay, if you didn't know that, that's something you'll learn later on in the semester when we talk about pain meds. But I say this because, if you're working in a hospital, a patient isn't moving as much, so they should be on a stool softener, right? They're going to be more at risk for constipation. But in the hospital, you have a lot of patients who have just undergone surgery, and so they may be treated for pain, and those the pain medications, the opioid pain medications, actually slow down GI motility. So now you have a patient who isn't moving as much because they're in a hospital, they just had surgery, and then on top of it, we're giving medications that slow down GI motility. So it puts them at very high risk for constipation. So those patients should be on a daily stool softener. Also, this is going to prevent somebody from straining after a surgical procedure. So if patients are bearing down and straining to have a bowel movement, they can actually vasovagal. That means that their heart rate and their blood pressure can drop significantly, which can cause them to pass out. So we don't want patients straining after surgery. Anybody who is at risk for constipation, really anybody, we should be encouraging fluids, exercise, and fiber intake. The fiber draws the fluid into the GI tract. The reason I have, again, at the top, don't give this for severe abdominal pain, because if you have a patient that's coming in with severe abdominal pain, we have to figure out what the underlying cause is. If it is a GI obstruction, we don't want to just treat with medications. It may need a surgical intervention or some other types of medications to treat that. And then there are laxative medications that we can give for constipation. Again, you usually start with the least, so the stool softener, and then we can move up to a laxative. There is a potential for laxative abuse. So you want to watch for that. And again, we don't want to give for severe abdominal pain. So what is the difference between a stool softener and a laxative? So a stool softener is going to really soften the stool by drawing in fluid. There's actual oil in that stool softener, so it's going to soften up the stool so that it makes it easier to pass. With a laxative, you're actually stimulating the bowels to work faster by stimulating the nerves to generate or cause more activity to produce a bowel movement. So there's definite difference. Again, you would start with, a patient who is mildly at risk at home. You would say encourage activity, drink water, increase your fiber intake. And then we would add possibly a stool softener. And then, for somebody a bit more severe, we would add in the laxative to stimulate that bowel to move. But again, we want to watch for severe abdominal pain. We are not treating severe abdominal pain with this. We always have to find the underlying cause. So there is some laxative abuse for a couple of reasons. One, if you have somebody who's using laxatives a lot because they stimulate nerve endings, at a while it's going to take more and more of the drugs to stimulate those nerves, so you need more and more of the drugs. it could be that you have somebody with an eating disorder abusing laxatives because they're trying to use this to promote some weight loss. With that, you'd have to be very careful because, if you have somebody who's having these very loose, very frequent stools, then we could be looking at, malnutrition and electrolyte imbalances. But in general, these are safe to use with most patients. Now, on the other side of things, we might have somebody who has pretty significant diarrhea, and so we want to treat that diarrhea. So the med that we would use for this is dipenhoxylate atropine. This is Lomotil is the brand name for this, and then the other drug that you might see is loperamide. These are opioid drugs. These if used, could cause some fluid and electrolyte imbalances. They can cause some cardiac arrhythmias, drowsiness, and then on the other side, remember with drugs, I think I've said it before, that it's like the teeter-totter. We want to create balance for a patient who is out of balance. So, when we use these drugs, we're trying to bring the body back into balance. In doing so, we can tip them the other way. So you can have somebody having very significant diarrhea. We treat them with one of these drugs, and now they're constipated because of opioids. Usually when we talk about opioids, we talk about medications we're using for pain, right? And I think I said that earlier on. If you have somebody being treated with opioids, we should have them on a stool softener because the opioids slow down GI motility, so that things are going to stay in the GI tract longer. So we are using opioids now to treat diarrhea. And then we have drug therapy for irritable bowel disease. You can see a sulfa antibiotic used for this. This is Solazine. So we do have to watch for sulfa allergies. With any antibiotic, we're always teaching patients to take the entire course. We want to watch again for that sulfa allergy, and then we want to monitor the CBC and monitor for joint pain. It can take several weeks for the medication to start working, and so they should just keep taking the prescribed dose. Even once they start feeling better, they want to again take that entire course of therapy because it is an antibiotic. And that's it for the GI tract. There aren't a ton of drugs for this. I know there may be some more on your med list. I would go over these, make sure that you are going through the review items for your third exam, which is going to have the cardiovascular drugs as well as the hematologic drugs. So, with this week 8, the GI stuff should not take you too terribly long to get through the modules. So just make sure that you're spending time going back and making sure that you're comfortable with week 6 and week 7. And then, as always, just reach out if you have any questions. Thanks.